Singh, are you there? Doctor, you're on mute. Good evening, doctor. Am I audible to you? और इंक्रीज करना पड़ेगा लग रहा है टाइमर। आई थिंक लाइव कर दिया है क्या तुमने? हाँ 6-5 कर दिया तो वेबिनार टीम लिखा हुआ है वहाँ पे ऐप पे टाइमर। 6 बजे शार्प। हाँ 6 बजे शार्प। डॉक्टर saying are you there? डॉक्टर के ऑडियो में कुछ इशू आ रहे हैं तो वो डिवाइस चेंज कर रहे हैं। हाँ तो डिवाइस चेंज करेंगे, प्रेजेंटेशन भी उसमें ट्रांसफर करेंगे। आई थिंक टाइम लग जाए यार, बहुत डिले हो गया। मैंने मैसेज भी डाल दिया है सबको 10 मिनट्स में एक भी लाइव। और बढ़ा दे क्या? दिखा रहे हैं ऐप पे। हाँ देखो 6:10 करना पड़ेगा मुझे लगता है, इतनी जल्दी कैसे करेंगे? डॉक्टर जॉइन आई डोंट थिंक सो। Okay. So good evening, everyone. We are we are live now. I can Aman. I think I can see 15-second timer. Is there a delay or shall we start? There's a delay. Okay. So I'll be starting in another 8 seconds from now. So I hope everybody has joined today's session. Yes, so we are live now. So good evening to one and all present here. I, Diksha Gambhir from Medisage E-Learning Private Limited, a platform for medical professionals to converge, enhance knowledge, exchange wisdom, and embrace digital solutions for advancing global patient care, welcomes you to our webinar on the topic regression of chronic liver disease, a myth or reality, addressing the entire CP and nephro communities. So it gives me immense pleasure to introduce our eminent speaker, Dr. AP Singh, a distinguished medical director and intensivist cardiologist at AP Hospital, Amritsar, who brings a wealth of experience in both cardiology and diabetes management. As an executive member of the Punjab chapter of RSSDI and a designate teacher for the DM, Dr. Singh is committed to advancing medical education and research. So, with the background of an assistant professor in the Department of Medicine at SGRDH Amritsar and a former teacher, registrar at GRMC Gwalior, Dr. AP Singh has been a respected educator and mentor. A sought after speaker at national and international forums, he is known for showcasing the intricate relationship between the mind, soul, and human body. So, doctor has contributed extensively to the medical field through numerous research papers and publication in books, medical updates, and journals. So, Dr. Singh's dedication to clinical excellence and academic contribution continues to shape the field of cardiology and diabetes care. So, I welcome Dr. AP Singh with a very warm heart, and I would like to hand over the stage to Dr. To set the context for discussion. So, doctor, over to you.
Thank you, MedSage, and thank you. I should thank you personally for introducing me so well. We will be quickly going on for today's talk. Probably we are already late and due to some technical reasons, but then what is the agenda for today is to talk about chronic kidney disease, specifically diabetic kidney disease, to be more precise, whether we are able to have some provisions for delaying its progression or going through some regression in the stages of this chronic disease, which is ever progressing once it sets in. So, being a nightmare for most of the physicians, most of the diabetes specialists, and even nephrologists who are dedicating their work and their profession in the well being of the patients suffering from kidney disease, what has grown over time is that we are passing through a phase which is quickly evolving in the treatment of chronic renal disease or chronic nephropathy. We had been through a very stagnant phase for last 2 to 3 decades when we had very less number of uh, armamentarium in order to look into chronic kidney disease. But of late, we have grown and we have found out that the newer modalities can really help in just for a minute. for a full screen this time if it is okay. Now is it full screen?
Doctor, the presentation, I think there's a hang that I can see. So could you please try and reconnect? Like, can you try and do the screen sharing process again? Only the presentation and not directly from the screen.
Okay.
So separately, you should open the PPT and then minimize it.
Background talking about all attempts to regress chronic nephropathy over next say half an hour or 45 minutes. What we'll be talking about all ways to regress or delay the progression of nephropathy. As I said, particularly diabetic nephropathy, and we'll be putting a reality check whether is it really possible in today's scenario, or still we have to work hard for it, where we have reached. Now these are the issues what I'll be addressing in another half an hour. So just reminding from past to future, what we had been doing for last 3 decades was only one thing, as we all know, was RAS inhibition. That means we were using either the ACE inhibitors or we were using the ARBs in order to put the things in order for last 2 to 3 decades, and we have been pretty successful in that. But then that was quite stagnant, and we were in search of something new. And there was a long wait since then, and now we are through some hopes. For last around 3 to 4 years, we have seen that the SGLT2 inhibition, which was primarily for the glycemic control, had shown very promising results both in the fields of heart failure, chronic kidney disease, and even managing ASCVD in diabetic patients. Of late, a new inclusion had been there, and that would be another part of my talk, and that is phenylalanine, which is a reformed mineraloreceptor antagonists. On the board is now the GLP receptor agonists also, and a recent study like flow study has shown that GLP receptor agonist will also be very soon part of the guidelines or would be used more frequently for the same purpose. But let me make you remember that above all, we have now started reviewing that there is a lot of hope if we can detect the chronic kidney disease at the earliest and start hitting it hard, so that these drugs can be better utilized in the early part of the natural history of chronic kidney disease. Once they are used early, probably they can benefit much more than when we are using it relatively later. There are some reservations which I am to make clear before I go further. That most advancements in the newer drug therapeutics were initially started with or being limited to diabetic kidney disease only. But what we have seen that very soon this spectrum has increased to most of the other etiologies of chronic kidney disease, meaning that we started with drugs, those were found to be benefited in diabetic kidney disease in proper, but soon realized that irrespective of the diabetic status, in various other etiologies, probably the same drug class was found to be useful or equally useful. That means patients without type 2 diabetes, and if they have CKD, even would be benefited in a similar manner. This applies to SGLT2 inhibitors in the beginning, and it looks that there are signals for finerenone also. And we will also see whether the the most new one in the basket, like GLP-1 receptor agonists, would also be used in non-diabetic patients for the similar purpose. So till then, we have the documentation in the favor of all the drugs for all the etiologies. Let me keep this presentation precisely applicable or in the context to diabetic kidney disease only. Let's come back to CKD and let's realize that why CKD is a challenge. One should be not astonished to know that CKD is the major global public health crisis, and its prevalence and the cost spent on the management is growing, and it is projected to go very high in very less amount of time in future. One can see that till 2021 to 2026, it would be up to 16% increase in prevalence, and the cost that will be implicated would be rising by 23% within these 5 years. And we know that the global prevalence of CKD as the volume of the disease is very high, and it is estimated to be around 840 million people living uh, in the world with a diagnosis of chronic kidney disease. So one can understand how much problematic this problem is and how much it is growing over time. One can understand that any chronic disease is growing because of obvious reasons, that the risk factors are accumulating because of the chronicity related to most of the diseases. Hypertension, diabetes, dyslipidemia, obesity are some of the examples which are the results of modernization. You can call it Americanization. And as a result, these risk factors, when they are put together, they are accumulating, and they have given rise to the things like intermediates called as diabetes. And once you have this intermediates, you have microvascular and macrovascular complications as the end results. And CKD happens to be one of the commonest microvascular complications related to diabetes. So one can understand why we are going to handle these patients in large number in near future as well as presently. The second important thing probably would be that we are living longer now, and the chronic diseases, when they are put to stay for a long time and the morbidity period continues to enlarge, it is quite likely that new and the higher and higher stages of the morbid diseases is going to add up. And CKD is no exclusion to this. And therefore, not only the morbidity issues like renal replacement therapy, as well as the mortality related to CKD, both are increasing worldwide. The deaths have increased up to 34%, and years lost, productive years lost in the life because of CKD are increasing by 21% over 10-year period. The number of people undergoing renal replacement therapy has increased by 100%, and are actually receiving or about to receive or in the need of renal replacement therapy, and they are suffering lot of morbidity and mortality because of CKD. There are various causes for this CKD. Of course, the hypertensive and diabetic nephropathy happens to be the most common. IgA nephropathy is less diagnosed but is quite common in the public, and you can see that there is around 6 times greater risk of cardiovascular death or cardiovascular events in a situation of diabetic nephropathy. Higher events in cardiovascular region is found to be multiplying by 3 times in hypertensive nephropathy as well. It is expected that 553%, that means again 1.5 times increase in mortality has been seen in a condition like IgA nephropathy, which is supposedly a less malignant condition than other etiologies of CKD. But one thing which needs much more attention is that irrespective of the reason you are suffering from kidney disease, whether it is type 2 diabetes or you are without type 2 diabetes, it really doesn't matter once the CKD sets in. What is being shown in this interesting diagram is that the CKD diagnosed by a fall in GFR and a rise in protein loss are both counterproductive, and both of them actually tangentially give rise to increased mortality risk and increased risk for end stage kidney disease. That means mortality risk and the morbidity risk both continue to rise irrespective of the initiating cause or the cause which has led to the uh, starting or origin of the chronic kidney disease. Once it sets in, a further lowering of EGFR or a further rise in protein loss further begets the same situation, what we call as CKD. What I mean to say is CKD begets CKD, and therefore, whatever the reason being, we need to intervene not only the reason, not only the etiology, but also the process of chronic kidney disease, which is progressing. And this is all what I'm going to talk about. And this is all what I mean by reducing progression, or what I mean by attempting regression in chronic kidney disease. If you come to the type 2 diabetic patients, you see this is the algorithm which is available to us from KDIGO guidelines 2022, and SGLT2 inhibitors have already scored in, they have entered into the algorithm for the first time as anti-diabetic drugs, as well as the choice to look into CKD progression or to reduce the risk related to diabetic kidney disease. GLP receptor agonists are growing up. They are guided by the patient's preferences, particularly in India, because they are still costly, and at certain point of time, probably other comorbidities, especially even the having of CKD, can limit their use because of their intolerance caused by the loss of weight, loss of appetite, and some nauseating and vomiting characteristics caused by the molecule itself. So SGLT2 as such forms a very important cornerstone as a recent management for the CKD with an attempt to delay its progression. As I said, GLP receptor agonists are growing. The flow study has shown sufficiently good signals and good results. And after some more data is accepted or some more data is in front of us, probably GLP receptor agonists will also form one of the important pillar or an established way to manage CKD. Once talking about SGLT2 inhibitor and giving an example of dapagliflozin, the DAPA CKD with dapagliflozin enrolled a diverse population of CKD in order to understand whether this molecule, this belonging to the SGLT2 class, is sufficiently efficient to reduce the morbidity by improving the GFR, by reducing the protein loss uh, monitored through UACR, and also whether this has some other benefits like preventing dialysis or prolonging the life of uh, diabetic renal patients, and other primary and secondary endpoints all put together. And they included both diabetic and non-diabetic patients. Of course, there were various others other than diabetic nephropathy, which was the most numbered ones, like 58%. But then you had focal segmental glomerulosclerosis, ischemic or hypertensive nephropathy, IgA nephropathy, and other etiologies also included in this DEPA-CKD trial. DEPA-CKD was the first trial to study the cardiorenal benefits out of SGLT2 inhibitor usage in both type 2 diabetic patients and non-diabetic patients with CKD. So this was a median follow-up of 2.4 years vis-a-vis placebo with one-to-one randomization, a big RCT to give us a very promising benefit in primary composite outcome, all cause mortality, and composite of cardiovascular death and hospitalization for heart failure. All these three things or these parameters are very much important if you look into the morbidity and mortality pattern of type 2 diabetic or non-type 2 diabetic patients with CKD. So there had been very promising 39% relative risk reduction in the primary composite outcome, 31% relative risk reduction in all cause mortality, and 29% overall, around one third of relative risk reduction, a very impressive risk reduction in most of the parameters. What was more important, once they saw into the diabetic patients or near diabetic patients like pre-diabetes, and when they compared the benefits were irrespective of the glycemic status. This indicates again for more than one time that it is not the diabetic nephropathy which can be handled efficiently with dapagliflozin, but even the normal glucose holding patients or non-diabetic patients or even the pre-diabetic patients, all of them, irrespective of their glycemic status, showed impressive benefits both in the primary composite outcome and all cause mortality. If you see the subgroups within the diabetic nephropathy, you find out and you can see this forest chart, and easily it is shown that whether it is primary composite outcome or it is all cause mortality or it is composite of cardiovascular death or hospitalization for heart failure, all the dots are in favor of dapagliflozin, except that you can see that composite of cardiovascular death and hospitalization for heart failure could not reach to the statistical significance. However, most of the other conditions and the parameters in most of the etiologies related to chronic kidney disease were in the favorable way benefited by dapagliflozin. Amongst the real benefits, when it was seen in the subsets like IgA nephropathy and the focal segmental glomerulosclerosis, a very impressive reduction in the risk was seen in primary composite outcome, and also the difference in the annual GFR decline over time, and this favored very grossly in the favor of dapagliflozin usage. This again brings me to the point that irrespective of the diagnosis of diabetic kidney disease, non-diabetic kidney disease as well benefits from SGLT2 inhibitors. So we are not far from now the final concept that all chronic kidney disease patients, they get benefits from dapagliflozin. If you put the renal and the cardiac parameters together, the cardiorenal and mortality benefits, those were observed in DEPA CKD, were consistent across all stages of CKD. Again, a very interesting finding that we have found out a drug class or a drug itself which can be used in any stage of chronic kidney disease. That means even up to CKD stage 4, you can see that the relative risk reduction of 27%, which is again a very robust figure, can be obtained in the primary composite outcome. Well, if you use early, like in CKD stage 2, 3, the relative risk reduction and the benefits are still better. So what I mean to say is that we should use early, try early, but we should not restrain using them in the later stages as well, because the benefits can be obtained even in the late stage like stage 4 of CKD when we are using these molecules. But let's see whether this is all or we have reached to the holy grail, but it's not like. If you see these charts, you can find out that within the patients of CKD, within the cohort of CKD, there does remain a big amount of residual risk. Of course, we are able to reduce the residual risk vis-a-vis losartan in renal trial, which has reduced down with the use of canagliflozin in Credence trial, and it will further reduced in DEPA CKD trial, but and more or less same reduction in EMPA kidney trial. But you can see there remains a residual risk across the board, even after usage of ACE inhibitors, ARBs, and SGLT2 inhibitors put together. That means we should find out some more ways to look into the regression or delaying the progression of chronic kidney disease. And the rest of the presentation will talk about finerenone, where we will be establishing its role in this residual risk area, this residual risk group of patients. Those are being already benefited from proper use of ARBs and a very proper use of SGLT2 inhibitors. Well, whether we are going to benefit these patients over and above the usage of ACE inhibitors and ARBs, and even if they are being prior treated with SGLT2 inhibitors. If you see this slide tells you one more important finding, which is going to help us in understanding further presentation, is that through ACE inhibitors and ARBs, we were actually looking into the hemodynamic control, which is being implicated to harm the kidney. So this control in terms of hemodynamic is very well managed with ACE inhibitors and ARBs, with the reduction in the glomerular pressure, which reduces the continuous damage on the glomeruli, leading to loss of proteins through the filtration, and managing both the albumin as well as the GFR components of the kidney. While we use SGLT2 inhibitors, it is more of a metabolic control, partly from the glycemic control, but definitely over and above the glycemic control. We have number of other reasons to believe that SGLT2 inhibitors help kidney patients, mainly through the tubular glomerular feedback mechanism, again a mechanism which is related to hormonal and metabolic control. This tubular glomerular feedback correction again augments the effect of any ARB or any ACE inhibitor which has been used prior to SGLT2 inhibitors. That means with the background of RAS inhibition, SGLT2 inhibitors continue to give additional benefit. So the afferent and efferent pressures are independently managed with the ACE inhibitors and ARBs on one side and SGLT2 inhibitors on other side, therefore making true balance for a very professional way to manage the GFR as well as protein loss. Then still there is a residual risk, meaning that there must be some other mechanisms on which we need to work upon, or we have to augment these processes which we are already using with the help of ACE inhibitors, ARBs, or with the help of SGLT2 inhibitors as a combo with the standard of care treatment. This slide again documents the hemodynamic mechanisms through ACE and ARBs, metabolic mechanisms by anti-diabetic drugs, specifically the SGLT2 inhibitors, which contribute to the hemodynamic uh, area by completing through the TGI or through the tubular glomerular feedback inhibition. But then what is left is on the right side of this slide, in the yellow circle, you can realize that inflammation and fibrosis, which continues to be an important pathophysiological mechanism to reduce the function of kidney, remains unanswered or uncorrected. The driver like melanoreceptor antagonist through the correction of melanoreceptor overactivation may be an additional way to look into inflammation and fibrosis and therefore look into the uh, benefits of regressing chronic kidney disease or delaying the progression of chronic kidney disease. So this is a novel target, a novel co-target like inflammation and fibrosis, which is supposedly driven by the melanoreceptor overactivation. Melanoreceptor overactivation is seen in number of pathophysiologies, including hypertension, including coronary artery disease, including heart failure, but has been also seen in chronic kidney disease and diabetes. Putting chronic kidney disease and diabetes together, it is quite pertinent to look and postulate that probably if we have a model of chronic kidney disease with diabetes, what we call as diabetic kidney disease, with an heightened state of melanoreceptor agonism, a melanoreceptor antagonist like previously the eplerenone or aldactone may benefit this particular inflammation and fibrotic processes and can convert a scene in the favor of regression of chronic kidney disease. But let me take you to the limitations that those are related with MRAs and kidneys, and we all know that it is not just possible saying that MR antagonism can be a safe process for kidney. However, previously the MR antagonism had been well tried at the stage of myocardium, and it has been found as the fourth important cornerstone treatment for the heart failure with reduced ejection fraction and to some extent with heart failure with preserved ejection fraction as well, because both of these processes are associated with MR activation. There is a long scope of other conditions where probably MR activation can be countered with MR antagonism, but still we are in process of finding out right drugs for things like dysautonomia, sudden cardiac death, atrial fibrillation, myocardial infarction, necrosis, vascular phenomenon, and many other things. What has been already established is that MRAs are now the standard of care for the heart failure for reduced ejection fraction, and it has been well seen in RAILS, EMPhASIS, and EFSIS trial in various heart failure substrates like post-myocardial infarction heart failure, chronic heart failure syndromes, and there is no doubt about the benefits incurred through these molecule class. But to talk about the same class in a setting of chronic kidney disease was not possible because of the reason that the conventional steroidal aprenon and spironolactone were found to have safety issues with hyperkalemia and some uh, progression in possibility of progression of chronic kidney disease in association with RAS inhibition. These were two limitations, those always uh, stopped the researchers to include MRAs as the potential drugs for chronic kidney disease. But on other side, the research continued to show that there are more than one reasons of MR overactivation in a setting of chronic kidney disease, in a setting of type 2 diabetes, in a setting of combination of type 2 diabetes and kidney disease. And this is through different mechanisms listed on this slide, like increased ligand dependent MR activation by aldosterone, increased ligand dependent MR activation by cortisols, increased ligand independent MR activation via the oxidative stress, increased MR expression due to simple high albuminuric state in the urine. So such MR overactivation was realized by the researchers, but we were short of a right molecule to look into antagonizing, how to antagonize this MR activation. There were some signals from the studies like 4E LVH study, where enalapril and aprenon were used versus standard care for the purpose of LVH regression, and it was found that there was simultaneous regression in microalbuminuria also. So real world data and the research data was also in the favor of finding out something like an MRA which can be safely used in a setting of chronic kidney disease. But again, the issues were hyperkalemia, the issues were probably ongoing CKD progression with usage of co-use with RAS inhibition. So we were in a fix till then we could transmogrificate an idea that we need to convert an MRA class into a new class of MRAs, like which do not carry these two particular risks. Those were associated with the conventional MRAs in the form of potential for hyperkalemia and the potential for progression of renal disease in conjunction with ACE inhibitors. So this is what the phenomenon could bring. This is what we call as the transmogrification. What I mean by transmogrification in a word is to change or alter greatly and often with grotesque or humorous effect. That on one day you say that you are not required, on the other day you say that you are most required. This is a metamorphosis or a process which shows an abrupt change, and such changes have been seen in the medical history and in the medical discoveries earlier also. To make you remember, such thing happened when we were taught that beta blockers are contraindicated in heart failure, and we are recently being taught that heart failure requires the most important drug as beta blockers. Similarly, we were taught, you think of kidney, MRAs are contraindicated. Now we are discussing that think of kidney, now we need an MRA. And we have evolved into an MRA. And this is the phenomenon which was born as a potent, highly selective form. The difference being that it is highly selective, the difference being that it is non-steroidal, the difference being it has very good potential for safety, advantages over steroidal MRAs and to compare with non-steroidal ones can be seen in this table, and one can see that it is very highly potent. It belongs to MRA class, but it is non-steroidal, and this makes it highly selective for melanoreceptors, and it also makes it selective for in the form of tissue distribution. Previously, the conventional MRAs were uh, alternatively good for kidney, bad for kidney, good for heart. But then we have 1:1 equivalent ratio of tissue distribution, which makes it a drug which can be beneficial both for kidney as well as heart. Knowing that mineralocorticoid receptors are present in the myocardium, in the vasculature, in the kidney within the interstitium, and in the glomeruli as a part of vasculature. Other things that could have helped this new MRA would be that absence of metabolites, meaning that it doesn't continue to produce the disbenefit of hyperkalemia. It is selective for MR, that means it works in a very selective manner and leads not to certain other side effects like gynecomastia and other ones. Those are also problematic with the steroidal MRAs. Since the half-life is very short, this further makes it safe in terms of hyperkalemia, and if at all it happens, it makes it a manageable problem in the patients with CKD. So all these pharmacological, pharmacokinetic, pharmacodynamic differences between a conventional MRA and a new MRA makes Finerenone probably uh, uh, close to both heart, brings close to both heart and kidney. And here we see how now we have sufficient data in the favor of kidney as well as cardiovascular system benefits from Finerenone. So phase 2 and phase 3 designs were done. Phase 2 program showed ARTS program, which showed ARTS DN and ARTS HF. And these were safety trials to see that there was less hyperkalemia vis-a-vis spironolactone. This was efficacy trial where it showed that the dose-dependent reduction in albuminuria was there, and the HF1 showed that it was well tolerated with comparable safety to eplerenone. And the phase 3 program with Fidelio DKD and Figaro DKD is now known to us, where both the kidney outcomes and the cardiovascular outcomes are being studied. In Fidelio, the kidney outcomes were studied primarily. In Figaro, the cardiovascular outcomes were studied primarily. However, the secondary outcomes were the reverse of the primary outcomes, and therefore the pooled data from Fidelio and Figaro in the form of Fidelity could actually finally document that Finerenone has a very impressive role to play in various cardiorenal situations, including cardiovascular outcomes other than heart failure, and also very impressive outcomes in chronic kidney disease in the form of reduction in albumin loss and improvement in GFR status. So these are the targets like kidney and cardiovascular system, where the MR overactivation needs a blockade, and the blockade is now possible with a non-steroidal Finerenone. And you can see this cartoon which tells you that the pathological abnormalities like inflammation and fibrosis, both at the kidney and the cardiovascular system, probably in addition to the hemodynamic benefits coming out of the molecule itself and from the additional usage of RAS inhibition and SGLT2 inhibition, with the metabolic benefits from anti-diabetic drugs like SGLT2 inhibitors and the selective action of SGLT2 inhibitors on the tubular glomerular axis, all put together is going to make the management of chronic kidney disease much more easier, much more beneficial, much more encouraging for most of us, including diabetes specialists and nephrologists as well. Various biomarkers, not to name them and not to remember them, both at the myocardial level as well as at the kidney level, had been found to be remarkably reduced or changed in various clinical associations, and therefore there is no doubt that cardiac fibrosis, cardiac dysfunction, improvement in ejection fractions, improvement in wall stress, etc., would be the beneficial intermediate endpoints through which we can find out that various cardiovascular dysfunctions, particularly through the fine arts study which has been published 2 weeks ago, has shown that in a area of heart failure with preserved ejection fraction, Finrenon has shown positive results. This study is being at presently shown or being declared in European Society of uh, Diabetes and European Society of Heart Failure. Fidelio and Figaro, as I said, were the dedicated trials for CKD and cardiac failure outcomes, and these were the two landmark trials, just to show that Fidelio DKD had the primary composite endpoint in relation to kidney, and the Figaro had the primary composite endpoint related to heart. The secondary endpoints were reverse of this, and when the pooled data was in the form of fidelity fidelity trial, and both of these trials put together have shown benefits in both these areas. If you see the kidney area, the Figaro included a particular patients with albumin loss of second degree moderately increased, and less patients with A3 stage, but the Fidelio included more patients with higher glomerular function dysfunction. That means in terms of glomerular dysfunction, Fidelio had more number of patients. In terms of albumin loss, Figaro has more number of patients. So overall, kidney health was covered and the whole spectrum was expanded from Figaro to Fidelio and Fidelio to Figaro to encompass most patients of chronic kidney disease in diabetes setup. As I said, fidelity was a cardiorenal outcome compilation of both of these trials like Figaro and Fidelio in the form of fidelity as a pooled data analysis, and this further confirmed the benefits of individual trials, and the inference was drawn more with more confidence. Let me go through some of the data benefits where you can see in this uh, chart there that the UACR versus placebo showed a very remarkable change in Fidelio as well as Figaro trial sets. If you see both Fidelio and Figaro in front of each other, so you can see there was decrease in CKD progression by 18% in Fidelio, and there was reduction in cardiovascular mortality and morbidity by 13%. So relative risk reduction was substantially good, statistically good in both of these parametric status. As the secondary outcomes, you had a 14% reduction in cardiovascular mortality and morbidity in Fidelio. However, the CKD regression was by 13% in the Figaro. So all put together, both trials could show benefits in both these areas. And what was very good was that there was not an increased incidence of hyperkalemia and had a very minimal clinical impact on anything like increment in the initial rise in creatinine levels, which was absolutely not there. A new parameter was also studied, which was said to be a very close to parameter of renal dysfunction, and that was a reduction in the risk of going up to a fall of 57% or more in EGFR with the help of a key drug. And it was found that there was 23% reduction in this parameter if you consider this parameter vis-a-vis placebo and finerenone. So there was lesser risk of going down by around 57% in EGFR in comparison to the placebo when finerenone was used against placebo. The safety was very important because this was the only hitch where MRAs were always discouraged in the setting of chronic kidney disease. The investigators found that hyperkalemia was not increased, and if at all it was there, it was not associated with a major clinical impact. If you pull down both of these data, you can see the Figaro and Fidelio again showed that the hyperkalemia leading to permanent discontinuation was very low, and hyperkalemia leading to death was zero, meaning that the overall 13,000 patient data over 3 years of median follow-up showed that the potassium management was not much required, but of course, a good monitoring would always be called off to avoid a major event with the usage of an MRA like finerenone. Very interesting slide, and this is one of the best ones I like because finerenone was studied in these two trials in a setting of patients without heart failure. And even in patients without heart failure, it was found that first hospitalization for heart failure, CV death for heart failure, or first hospitalization put together, CV death and first hospitalization for heart failure put together, in this forest chart showed that finerenone actually did favored the outcome significantly, meaning that I see finerenone as an anti-heart failure drug as well in future, and probably as also in a situation like primary prevention of heart failure in high risk patients with heart failure. So with high risk patients for heart failure, to avoid the first hospitalization for heart failure, this is probably would be a de novo drug to think about. And there are signals from Figaro and Fidelio, and about 8% of patients in Figaro had history of heart failure, but 92% of patients were absolutely without history of heart failure. So in a patient group which was healthy in terms of heart failure also showed benefit in future heart failure outcomes, meaning that primary prevention of heart failure is not far off, and we can think of this drug for the primary prevention of heart failure as well. Another area which has been again a difficult task to predict is sudden cardiac death. But then we had the pathophysiological basis for sudden cardiac death, which was associated with menoreceptor overactivation and antagonism, which can reduce arrhythmias, atrial fibrillations, and other causes for sudden cardiac death can be maneuvered. And it was found that there was a definite benefit in sudden cardiac death predicted with finerenone once it is used for uh, mm, for the CKD and the other cardiovascular benefits, and the sub-study of Fidelio or Fidelity could document a reduction in sudden cardiac death with finerenone. Again, a similar type of benefit that we found out with SGLT2 inhibitors, the benefit coming out from this class of drug also is independent of the stage in which we are operating upon. Even in stage 4 CKD patient, there had been a favorable outcome with the civic outcomes and kidney outcomes. from the fidelity data. Around 7% of patients in fidelity had stage 4 CKD, and this could make up a good number out of 13,000 patients. And therefore, one can think that the molecule is operating both in the early phase of CKD, also in the later part of the natural history of CKD. Whether the patient had been on SGLT2 inhibitors or not, however, the number of patients not being many, around 6.7% of patients were previously treated with SGLT2 inhibitors in the fidelity. It was very well documented that more or less similar benefits in reduction in urinary albumin creatinine ratio was seen with phenylalanine vis-a-vis placebo. So therefore, there is no reason to believe that we can have incremental benefits with SGLT2 inhibitors and the phenolones when used together. In fidelity, the similar thing had been again seen, that the cardiovascular outcome, hospitalization for heart failure, eGFR, as managed or as monitored by 57% outcome or by 40% outcome, have been very useful. I will take a second so that I can make my dog silent. Kindly cooperate. So, coming back, this slide is to tell us that not only that the hyperkalemia was not an issue with phenolone, the sexual side effects, the other adverse events, and any other event that can be expected from non-selectivity with the aprenon or spironolactone was not found to be associated with phenolone. There was, however, some benefit in blood pressure. There was no change in A1C, neither hyperglycemic signals or hypoglycemic signals were seen. So it doesn't change the glycemic status of the patients of diabetes with kidney disease, and therefore this is quite safe in all respects. Putting everything together, now we know that RAS inhibitors and phenolone and SGLT2 inhibitors will form the three pillars of standard of care, and European Society of Cardiology had uh, actually accepted this as far as the cardiovascular risk and the kidney risk is concerned in type 2 diabetic patient cohorts, and therefore we have sufficient evidence now that after SGLT2 inhibitors, phenolone can be co-used with RAS inhibitors and SGLT2 inhibitors in one or the other way to further augment the benefits related to kidney as well as cardiovascular system. So reaching to the end of my presentation, there are certain other extraordinary things with phenolone which I feel are very important to remember. This is a molecule which looks into a novel way to control the kidney process which is forward, like inflammatory pathway and the fibrotic pathway. This comes through a very balanced appearance in kidney and myocardium. One should remember that it's just not another MRA. It is belonging to the class of MRA, but it has distinct differences. Those had made it a novelty. It is potent both for the albumin loss management and as good for the kidney GFR correction, meaning that it works both early as well as late. What has been seen with most of the kidney therapies, that there is an early injury to the kidney which stays for a few weeks or months in the early phase of treatment. This has not been seen much with phenolone. There are less hemodynamic effects, and that's the reason that kidney doesn't show a fall in GFR in the beginning, or the potential for AKI in the beginning is minimal. Cardiovascular benefits are huge, and one should note that they are not driven through heart failure alone, as it has been seen with SGLT2 inhibitors. So we have direct mechanisms on myocardium where it is probably acting on the wall stress, it's acting on the myocytes. It probably will be useful in heart failure with reduced ejection fraction as well, had been proven in heart failure with preserved ejection fraction in the new fine arts study, which I was mentioning is being shown nowadays in the European Society of Cardiology. Overall safety has been exceptional. The hyperkalemia issue is minimal. If at all it is there, it needs just monitoring. Major issues like death due to hyperkalemia has not been seen in the studies, those I have mentioned in the RCTs. Very good points like natriuresis and potassium management in an optimum manner can be further useful when it is co-used with SGLT2 inhibitors, because natriuresis is a fundamental mechanism through which SGLT2 inhibitors actually operate. It supports, therefore, the SGLT2 inhibitors while they are working for chronic kidney disease, may reprime kidneys for reuse of RAS usage, because its effect on kidney makes a GFR more acceptable for RAS, which is an established therapy, RAS inhibitors, which is an established therapy, and sometimes we are not able to use because of the intolerance seen with RAS inhibition due to sudden fall in eGFR or change in potassium levels. And one can think of many, many more benefits because of this phenomenon. So to conclude, once again, I see a lot of hopes with SGLT2 inhibitors, phenomenon, and co-use of these molecules in the area of chronic kidney disease, shifting from diabetic kidney disease to start with, of course, diabetic kidney disease, but soon in even non-diabetic kidney patients also would be benefited equally as what one can speculate. Thank you for the patient listening, and this is the last important slide, which actually is to make my point clear that if I truly follow and extrapolate my kidney patients, my heart failure patients, my cardiac patients to be truly like cardiorenal patients, and put all my armamentariums together along with lifestyle modification using ACE inhibition or ARBs, using SGLT2 inhibitors and phenomenon in right patients, well selected patients with good monitoring, probably the kidney will age as it would have aged in an healthy patient beyond 50 years of age. So I see a fair change in the outcomes of kidney patients or prevention of kidney disease in high risk patients like type 2 diabetes, hypertension, heart failure, obesity, and other risk factors from chronic kidney disease. Thank you very much.
Doctor, for the wonderful presentation. So we have some questions in the chat box. So we'll take up some of those questions. If you have already covered them in the presentation, you can skip, or maybe you can answer in one line.
All right.
So, yeah. So we'll be beginning from the first question, and that is from Dr. Arjun. And he is asking, what are the limitations of current RAS inhibitors in slowing CKD progression, and what alternative therapies are being explored?
These two alternative therapies or add-on therapies are being well explained in this presentation. The limitations with RAS inhibition had been that in certain group of patients, we encountered a form of intolerance to RAS inhibition in the way that RAS inhibition showed unaccepted, extraordinary, more than expected change in potassium levels and some deterioration in EGFR, and therefore it was always that we need to monitor them in most of our patients. But in rightly selected patients, this phenomena had not been there, because this phenomena of hyperkalemia and fall in GFR would be restricted in only patients those are not properly selected, those with low EF, those with high amount of doses of diuretics, those with severe cardiorenal shutdowns, those with renal artery stenosis, which we are not knowing. So, if we select patients out of these high risk patients, RAS inhibitors did very well. But if you remember my slide after SGLT2 inhibitors, I've shown you a good amount of residual risk continuing in the natural history of CKD, which was uncorrected, unattended by RAS inhibitors and even by SGLT2 inhibitors. So we need more and more drugs. We are never satisfied. By using ARBs in renal trial, we had definite benefits of around 30 to 40% risk reduction. But then that risk reduction was not sufficient. That is not the utmost. That is optimum, but not complete. So we went for SGLT2 inhibitors. After 30 years, we could get that. By chance, I believe. We never thought of SGLT2 inhibitors to benefit kidney patients. But then Phenenon is a well-designed molecule, well thought of molecule, which is going to further reduce the residual risk. So the limitations are residual risk and some amount of deterioration in GFR in unselected patients.
Thank you so much, doctor. So moving on to the next question. How does dapagliflozin affect the risk of diabetic ketoacidosis in patients with CKD, especially in those with type 2 diabetes who are in insulin dependent?
That's a very beautiful question. With SGLT2 inhibitors, we had been shown that there is an extra risk of diabetic ketoacidosis. To be more precise and correct, it is not diabetic ketoacidosis, it is euglycemic ketoacidosis. The glycemia comes from SGLT2 inhibitors, which strongly corrects the glycemic burden and strongly corrects the lipid burden, lipotoxicity and the glucotoxicity. As a result, there is very good control over glucose and the lipid parameters. In patients, those are already being treated on insulin, will not suffer with any amount of ketoacidosis. The only problem will arise if we stop insulin once we are starting SGLT2 inhibitors, which we should not do. Because SGLT2 inhibitors actually enhance the catabolic state by removing the calories from the body, by removing glucose through the urine, as a result of which it brings you to a substrate like which is prone to ketoacidosis. That is the definition of euglycemic ketoacidosis. But all of us know that never a ketoacidosis can appear if even a small amount of insulin is available in our body. So we should never withdraw insulin from the prescription if the patient is already on insulins, just for the reason that we are using SGLT2 inhibitors. Otherwise, we may push the patient towards euglycemic ketoacidosis. In patients, those who are catabolic and losing weight very fastly, and an SGLT2 inhibitor is prescribed, I would suggest to use some amount of insulin in order to have the good acceptance of SGLT2 inhibitor so that this bad side effect will not appear.
Thank you for the detailed answer, doctor. So moving on to the next question from the same doctor. What are the implications of dapagliflozin effect on proteinuria in CKD patients with varying levels of albumin, urea, and should albuminuria be a key factor in deciding which patients receive the drug?
Albuminuric patients as well as the GFR altered patients both had shown benefits with SGLT2 inhibitors. So SGLT2 inhibitors operate on both mechanisms of albumin loss as well as GFR. So there is no reason to believe that the kidney health is benefited only through GFR benefits or only through albumin loss management. So reduction in effective GFR, effective glomerular filtration pressure in conjunction with RAS inhibition helps to restore kidney health, and therefore uh, there are no selective patients in which like SGLT2 inhibitors are not to be used, whether it is microalbuminic, albuminic, grossly albuminic, with GFR, without GFR alterations. You can be benefited, you can get the benefit in all subsets of patients. So I would use SGLT2 as a pan CKD manager. Similarly, Fenanon is also pan CKD manager because you have seen in the Figaro and Fidelio, both the albumin losses reduced, GFR improved, and the cardiac events were also corrected.
Okay. So, Doctor, moving on to the next question. How can we address the high cost of newer CKD therapies such as SGLT2 inhibitors and GLP-1 receptor agonist in resource limited settings?
Obviously, this is a very, once again, a very worrisome point and really a very good question as well. Uh, to some extent, dapagliflozin is now available uh, other than the primary researcher product. So we have now the biosimilars. I'll say I'll not call them generics, but I'll call them biosimilar drugs. Dapagliflozin is available at a low cost now, so one can use SGLT2 inhibitors in that setting. But obviously, the finerenone is not available at a low cost at this moment. There is still the patent on with finerenone, so maybe after some time we can have this molecule. GLP receptor agonists are again costly in India, but they are far less costlier than what we see in the West. So you must be knowing that there is Ozempic crisis going on all over the world. The GLP receptor agonists like Ozempic is in huge need in US. People are fighting for Ozempic for to have benefits in obesity management as well as diabetes management, and there it is very costly in comparison to the Indian setting. So I'll say 2 points. Still in India, the molecules are not that costly. Of course, costly for resource limited settings, but then there are cost benefit ratio studies being done with these molecules, and if you put them on the board, you will find that that the chronic kidney disease as a whole, a need for renal replacement therapy in the form of continuous dialysis, in the form of renal replacement therapy with kidney transplantation, are much more costlier than these drugs. So I still believe they are cost effective.
Yeah, thank you so much, Doctor. So we have one or two more questions. So, what are the optimal strategies for treating CKD in the patients with concomitant liver disease, that is cirrhosis, given the potential for altered drug metabolism and renal hepatic syndrome?
See, the hepatorenal syndrome or the renohepatic syndrome are not the areas in which these drugs have been studied at all. As I said, we have started with diabetes patients, diabetic patients, and moved on to chronic kidney patients from different etiologies. But as far as the liver relationship with these molecules is concerned, has not been studied. So I would restrain giving any statement in the favor of these molecules in this complicated setting like hepatorenal shutdown or renohepatic syndromes. These syndromes are very exclusive pathophysiologies and therefore should be tackled with conventional means and methods what have been available to us, like telepressin or splanchnic circulation management and albumin supplementation, intravenous albumin, and all those things. Those are known to renohepatic specialists. So these molecules are not for those situations. Still, in a diabetic situation, which is safe for kidney, which is safe for liver, I would say that GLP receptor agonists are relatively usable, because we have study like flow study for kidney management, and they are not hepatotoxic in most of the lower CP scores for liver diseases. Then uh, linagliptin is again a molecule as DPP4 inhibitor for glycemic control, which has shown some benefit in kidney disease, just signals towards kidney disease, and absolutely safe in kidney and renal diseases, kidney and liver diseases. So can be an option for glycemic management. So other than if you're looking for some anti-glycemic agents, then sulfonylureas in low doses are also safe. Leaving aside SGLT2 inhibitors, they are not being studied in liver patients, so I would not recommend them. Other DPP4 inhibitors are less safer than linagliptin and teneligliptin. Teneligliptin is also safe somehow. Then uh, metformin is unsafe after a particular cutoff of 1.5 and EGFR values. We all know about, all diabetes specialists know about this, and I already talked about sulfonylureas. Glitazones cannot be used for any of them because they are associated with water retention and propensity to cause heart failure, so I would not recommend them. So for from the diabetes background, from the liver background, from the kidney background, we would always be safe with insulins. For the pro benefits coming from molecules, GLP receptor agonists may have some benefits. Finrenon again has not been studied in liver patients. So I would not extend any of my thoughts towards these difficult, exclusively different situations studied in these big trials.
Great, doctor. Now we have one last question for you to answer, and that is: could the mechanism of the finerenone be leveraged to develop even more targeted therapies for kidney disease, particularly for conditions with a high fibrotic component like diabetic neuropathy or IgA neuropathy?
Phenomenon for different situations had been also studied, is ongoing. As I said, heart failure for preserved ejection fraction, the fine art study has already come out, and other situations also, like wherever the fibrosis exists and wherever the mineral receptors are present, and wherever the drug concentrates. So you need a lot of things before you think of a drug to be used in different settings with similar mechanisms of diseases. I was thinking, as you are thinking, one who has put this question, absolutely a very intelligent question. Could it be a molecule for fibrosis management in the liver, like cirrhosis of liver? Because I know there are immunoreceptors present in the liver. But then, unless we study all these things, those are very not very easy to study till we design good trials for them. But there is, of course, good potential to use Finrenon in the arrhythmia management, in the vascular management, in the anti-necrotic management of myocardial infarction, in the management of CAD as such, in the management of autonomic dysfunction, as I shown. These are the various areas where mineroreceptor overactivation is evident. So what you need for a molecule like MRA used is you have to define an overactivated state. That's why we have chosen CKD and type 2 diabetic together. Otherwise, we have chosen non-diabetic as well. So we wanted to establish that type 2 diabetes plus CKD, which is an hyperaldosteronic state, we have to document the benefits in that high state. Once we have documented it through these trials, we can think of other conditions where MR overactivation is evident. Then we will see whether the phenolone is concentrated in that molecule, that area. Then we'll see whether the even the receptors are present in that area. So not many things need to be studied before we go into this new thought process. But then this is very interesting and very good to think about.
Great, doctor. So all the questions have been very well answered by you in great detail, and I hope my audience have understood in detail the concept of regression of CKD. So now it's time that we move towards the closure. So,
Yeah.
doctor, we would like to, extend our heartfelt gratitude to you for your invaluable time and presentation. The webinar was exceptionally insightful, featuring rich knowledge and elaborative information on regression of chronic kidney disease. We believe our audience found it both enjoyable and informative. We look forward for more such educational webinars on interesting topic like today's in future as well. So, in case any of you, the audience, has missed this interesting and informative webinar, you can tune in to the past section after 30 minutes of this webinar, and you can keep yourself updated with all the discussion that has been done today. And later you can watch it in the video section forever. So thank you so much, doctor, once again for joining in. Namaste.
Thank you, Matt Sage, and all of you, the host. I'm exceptionally thankful to you and those who had been listening, those who had joined and had been continued to listen. I would like to thank for their precious time they have given to us and to the science as well. Thank you very much.
Thanks, doctor. Thank you so much. Good night.